Let's go ahead and get started today talking about chronic liver disease. We sort of talked about yesterday that chronic and acute liver disease was a somewhat artificial separation because you can present acutely with a disease that proves to be chronic. But in a way, the injury of chronic disease is different from the injury of acute disease in a way that's also kind of intuitive. If you're a sprinter, you can pull a hamstring. It's an acute event. You see it when it happens. If you're a long-distance runner, you get shin splints. You get shin splints over time. You get tubular band over time, and it's a chronic thing. They feel different. Well, the same is true of liver disease. There are acute diseases. There are chronic diseases. The injury pattern is different. So today we're going to talk about chronic liver disease, and in particular, I want to convince you that the microanatomy of the liver is crucial to liver disease, and if you understand it, you'll really have a huge advantage in understanding liver disease as you learn more and see more of them. We'll talk a little bit about signs and symptoms. We'll talk about prognosis, and especially how we gauge prognosis, because a lot of treatment, of course, depends, first of all, even in discovering or sorting out whether it's useful or not. You have to have a population of patients whose prognosis you understand well enough to see how your treatment affects it, right? If you have apples and oranges and you do a treatment that's good for the apples and the whole group as a group doesn't do well, it might be because you haven't separated out the people who are sensitive to the treatment from those who aren't. So figuring out prognosis turns out to be very helpful. And then we'll talk about the manifestations of chronic liver disease and how some of them are treated, at least in an overview kind of way. We don't have time for a lot of things to do with liver disease. This is just a list to impress you that the liver really is the boss of the body, because if you have liver problems, you have hepatopulmonary syndromes, portopulmonary hypertension is a possibility. There's a cardiomyopathy of liver disease. Sarcopenia, or the loss of muscle mass, is quite characteristic of liver disease. Hepatorenal syndrome is a lethal complication. So, kidneys, heart, lungs, all of them are affected by the liver and have important clinical manifestations. We will end up touching on hepatocellular carcinoma just a little bit and transplantation just a little bit, but there's a lot of stuff we just can't get to. The liver is the boss of the body. I don't know if you ever heard B.B. King sing you pay the cost to be the boss, but that's kind of the way it is with chronic liver disease. It bosses the rest of the body. We kind of touched on this yesterday. I'm just going to remind you that acute disease in general takes place over days to weeks. The injury is transient. There's normal recovery. The liver 20 years later would look as though it had never been injured. You could have severe hepatitis A or ischemic change and recover completely. But chronic liver disease takes place over months and years, and really decades, characterized by chronic injury, low grade but ongoing, unrelenting, and typically results in a very significantly degraded function and ultimately the evolution of scarring of the liver, which is responsible for most of the mischief. So they're just different in character. This is a recovery. This is a long-term, ongoing scar formation, distorting the architecture of the liver, as we'll see. The ultimate result, the worst case scenario, but the typical kind of final destination, is cirrhosis. The Greek yellowish or tawny, the liver often has that appearance, but I would say it's the definition of it, you'll see different definitions, but it is always characterized by chronic and diffuse fibrosis. Patients often say, how much of my liver is affected? 30%, 40%? Well, cirrhosis, the whole liver is affected. Now, to what degree it's affected varies, because this is a spectrum, like everything in liver disease, but it requires a kind of leisurely, low-grade, ongoing injury with repair. The repair is simply not effective in restoring the architecture, as we'll see, and typically the processes that cause the injury are causing cell loss, especially hepatocytes, but all cell lineages, and the regeneration is inadequate or distorted. And that results in a very distorted architecture with impact on all those conduits that go through the liver. We talked about the 5 anastomoses yesterday. There's blood flow and there's bile flow. All of those are affected when the matrix of the liver is constrained and squeezed and altered, as we'll see. And then furthermore, the function of the cells themselves is affected when their surroundings are disturbed. Liver cells, like most cells in the body, depend on their neighbors and the reliable architecture of their surroundings to behave properly. And when they're surrounded by scarring and their matrix into which they're embedded is is lightly embedded, but to which they're still in touch, is distorted, then their phenotype changes. They behave badly. If you take liver cells and plate them out on plastic, they behave differently than if you plate them on collagen, than if you plate them on the other kinds of matrices. They're very sensitive to their surroundings. The regeneration of liver is sort of fabulous, honestly. I mean, this is Prometheus gave us fire, and as a reward, his liver was eaten out every night by an eagle and regrew the next day. Patients will often ask, I heard livers regenerate. I don't know why they know that. Yes?
I think your microphone's putting off a lot of static.
Oh, should I just turn it off? Am I loud enough? Yeah. All right. Great. I don't know why patients all know this. They all think their liver is going to regenerate, and it's true. The liver can regenerate fabulously. If you take a mouse liver and take off a third of it, within a week it'll have regrown to the gram. It won't have quite the same shape. It'll have totally the same architecture. And the same is true in humans. If you transplant a liver from a living donor, both the donor and the patient regrow the liver, but they have the advantage of normal architecture. That's an acute injury. That's part of the difference between acute and chronic. The liver can regenerate when it's preserving its scaffolding, and this is the cathedral in Milan with scaffolding over this particular steeple. If you would imagine a process that blew out every brick but left the scaffolding, you could kind of imagine rebuilding it. But if the scaffolding is gone, and in this case the scaffolding in the liver being that matrix, that extracellular matrix, then you got no plan, and then the regeneration is thwarted and altered. So patients need to hear, the liver can regenerate if it starts out being normal. But you're asking me about regeneration now when you have cirrhosis. It's not going to regenerate. The matrix is distorted, and we'll talk about that. Here's a normal slab of liver. Dr. Hansen showed something like this yesterday with some vessels going through it, and a little, some sideways, some transverse. Here's a cirrhotic liver. It's a liver that's fairly substantially cirrhotic. It's not subtle, right? You can certainly see that it has become nodular and irregular. You could imagine that with good imaging it would not look normal on an ultrasound or a CAT scan. That's the result of regeneration, that it takes place without architectural assistance. Cirrhosis itself is the common final pathway of all chronic liver diseases. The differences between them in mechanism are maybe important pathophysiologically and by importance to people thinking about therapeutics, but the appearance is pretty uniform. And if you look at a cirrhotic liver, it can be very difficult to tell how it got that way. Even fatty livers may lose the fat in the process, and then they just look cirrhotic, and you don't really know why. It's about the fifth leading cause of death in men, more in men than women. It's a little lower there, but overall in this country, it's sometimes in the top 10 or 11, depends a little on the year. 2009 was number 12. I think we're actually at number 10 now. And moving on. It's a silent disease, and by that I mean most people just don't know they have it until they have manifestations, which are late. People don't say, gee, I think I have symptoms of cirrhosis for the first time. Well, I should put it the other way around. They do think they're getting cirrhosis quickly because the symptoms may come to their attention quickly, but the process typically takes decades of slow progression, and there's rarely a substantial reversible component to it. There are some exceptions, but by and large it's progressive, and you aren't going to get rid of scarring once it's formed. The causes of cirrhosis are those liver diseases we touched on yesterday that have the potential for chronicity. This slide's a little bit old, but I've kept it because it's also meaningful how things have changed. The biggest slice of this pie, this is from the Oregon Health Science University, and it's their transplant data. Basically, the biggest slice, viral, means hepatitis C, mostly, a little bit of hepatitis B. They have a little hepatitis D up there, which is unusual, but that's the biggest slice of the pie, although viral plus alcohol is another substantial part, and alcohol is over here. So you can see that once you get rid of virus and alcohol, it's a relatively small part. Autoimmune liver disease, hemochromatosis, this might be where somebody with cirrhotic Wilson's disease might be. And then there's this section that was at the time of the slide called unknown. almost undoubtedly all fatty liver, and this piece of the pie has also increased in size. So fatty liver is the other big one, and in fact, by the end of this decade, it'll be the number one cause for liver transplantation. So those are the usual suspects, you might say. If somebody has cirrhosis, those are the things that you're thinking about from the very beginning. And, you have to think about it in part because if they're still present and ongoing, then the cirrhosis is still being driven and getting worse. Clinically, we talk about cirrhosis being either compensated or decompensated. This is just the nomenclature. There's nothing magic about it. What it means is if it's compensated is there really haven't been any symptoms yet. Symptoms or signs, for that matter, at least clinically apparent signs. Patient may have some fatigue, but most people who do think it's just because they're getting older anyway. We think of the liver as having enough functional reserve that at this point, even though there's been some of the damage we'll look at here shortly, has not been enough to result in clinical problems. So if you're presenting the patient, you say this is a 50-year-old with hepatitis C-related cirrhosis, compensated, and you move on, that tells you in one word the patient has not had any of those clinical consequences that the decompensated patient has. That's the patient that has ascites, or hepatic encephalopathy, or substantial muscle wasting, or jaundice, or varices, or perhaps the renal disease. In other words, all these badnesses that come with advanced cirrhosis. What we're talking about really is a spectrum between early scarring and advanced scarring, and we're drawing a line. It's an arbitrary line, but it's a clinically relevant line between those patients who have a reason to know they have something wrong and those who don't. So compensated and decompensated is the major nomenclature. You can get a little more refined and talk about whether patients have clinically significant portal hypertension. I don't think we'll probably end up talking about that today. This is plenty good. If you can make these distinctions on the wards, then you're already in the driver's seat for liver disease. So another way to look at the natural history of chronic liver disease is we're compensated, and then we develop, as the disease advances, one of these complications where we call them decompensated, and at that point in time, it's advanced. If somebody walks in with ascites from cirrhosis, they have advanced disease. They may feel like they just got sick a month ago, but now they're looking at a very short lifespan if nothing can be done about it. In general, the things that people die of liver disease acutely, that is from chronic liver disease, but the acute cause of death, bleeding from varices, possibly the complications of encephalopathy, infection of ascites. You don't die of jaundice, but jaundice is certainly the other major sign, and those are the things that we think about mostly as decompensation events. The probability of these things, this is in months, so 160 months is, 12, 13 years. By that time, almost 60% of patients will have acquired ascites. Most of them will be jaundiced, at least on paper. In other words, their bilirubin will be elevated even if you don't see it in their eyeballs. Encephalopathy has become prominent in almost 50%, and a substantial number will have had hemorrhage for mechanisms we'll talk about. So these are just inevitable over time, and that's not that much time, 10 years. Somebody comes in with ascites and they think they just got it last month. Their disease is at least 10 years long, and maybe 20. In some cases, it's that indolent. This is a patient with advanced liver disease, and you can see a little bit of, you can recognize there's something wrong. He's pretty gaunt. Upstairs, there's almost no muscle. He's got a protuberant abdomen. You can say in context, that's not fat, right? That's a belly that's distended with fluid from the inside. You probably can kind of tell his umbilicus is everted from the pressure of that fluid. He's got a lot of veins on his abdomen that don't look quite normal, and that's easy to tell. You could recognize that across the room. You could say that person has cirrhosis for whatever reason. That's the sort of worst case scenario in appearance. The prognosis of patients with cirrhosis, here's at the time of diagnosis and following them through. Again, 180 months is not that long. All patients with cirrhosis, probability of survival. This is all comers. And if you look at all comers, your median survival is less than 10 years. Okay, but if you're decompensated at the time you come to attention, which is more common than not, then your median survival is less than 2 years. Now that's assuming that the liver disease doesn't have some treatment or intervention. But this is a bad disease. Somebody walks in with newly discovered ascites from cirrhosis, they might as well walk in with lung cancer. It is just as grim a prognosis. Now it turns out there may be more we can do about it in some cases. But the thing I want to impress upon you is that when the patient walks in curious about these new symptoms and what's new with his disease, he's actually got advanced disease and he's in trouble. He or she is in trouble. So let's take a quick look then at this microarchitecture. We have these nodules, and let's sort of cone down a little bit and take us back through Dr. Hansen territory to what was actually going on down there. Today, maybe it's a little easier to hallucinate. There's a central vein, and there's a little portal tract. Will you believe that? When I was a medical student, I never saw that. I flunked that part of histology. I could never see it. But it's better when I have it on a slide, because then I know it's here. So this is a normal liver, and the blood is coming in the hepatic artery and the portal vein, percolating through all these cells and leading through the central vein and out the hepatic veins. So it's coming in through this lobule from all directions. And of course the bile itself is being generated by these cells, and it's going the other way and out the bile ducts in those portal tracts. That's normal. This is a cirrhotic liver, distinctly different. We see the big bands of fibrosis. You can kind of imagine how that could make a nodular appearance. We can't see at this level the scarring or the fibrosis within the architecture at the finer detail. But again, you can tell across the room, even if you can't figure out what's a central vein and what isn't, you can tell that's cirrhosis, right? That's just not normal. That's the end stage. So let's comb down a little bit on one of these lobules. This is scanning electron microscopy, and here's that central vein. And here are the portal tracts, and we see this is, after all, a three-dimensional structure where pictures always make it look like we're in flatland or something, but some of these veins have been sliced transversely, but you can still sort of get the idea. The blood is flowing from these distributing portal veins up to the central vein. You can almost see that these cells are in plates, or at least they're in columns or rows. Now, if we go a little closer and we look at those channels between the cells, here's a cell on this side, cell on this side, we're looking at what we call the sinusoids, that is the space in which blood is flowing from the portal vein to the central vein. And you see that's an irregular surface, and if you color down a little more, now we're within the sinusoid. And the remarkable thing is, it's full of holes. It's fenestrated, as we say. It has holes, it's leaky. It's so leaky that we're looking through a hole and we're seeing the microvilli of the hepatocyte on the other side. So we're looking through this structure of the sinusoid and seeing the cell surface. And now you kind of get a dramatic sort of feeling for how great the hepatocytes have. If you like living in the bloodstream, man, you're just bathing in the blood there. It's coming right through these holes, and you're constantly perfused. You can almost reach into the sinusoid and take out what you need. So the liver has a kind of unprecedented access to blood flow. And on the other hand, that means as blood passes through the sinusoids, its pressure is diffused through this leaky sinusoidal endothelium, and so it's hard to push pressure up in the liver, in the normal liver, because it's so spongy. The blood can leak out of all these holes. So this is a remarkable and unprecedented and unique aspect of architecture in the liver, the fenestrated sinusoids, and it just turns out that they are crucial, or their thwarting is crucial to the evolution of cirrhosis. Yesterday, I reminded you, hepatocytes are the boss of the liver, the major cell in the liver, but now we just looked at these endothelial cells that are fenestrated. And remember, they're Kupffer cells, those resident macrophages, and the bile ducts have to have their own cell type, and then there are these fat-storing cells. So let's put them into the picture here. These are endothelial cells that I floated out of a rat once years ago, and you think when you look at the cytoplasm here that these are vacuoles, but most of these are holes. If you can imagine building a tube out of these cells, you can see how leaky they are. This is a macrophage that snuck in there, but these are a dramatic example of how leaky these cells are in the sinusoids. So let's put it into a little cartoon to make it all fit together. Here's that portal vein, and here's the central vein, and instead of having a long column of cells in between, we just put it down to 3 hepatocytes on each side. And they're the little canaliculi from which this liver cells begin the secretion of bile. That's going to take on its own channel through the bile system. We're not going to talk about that. So here's the portal vein with the basement membrane around it. But when you get to the sinusoids, there are these fenestrations. And furthermore, there's no basement membrane, right? There can't be a basement membrane if there are fenestrations. So you've lost a basement membrane altogether. And this space that we just looked at, we were looking at the villi kind of protruding through it, is called the space of Disse, D-I-S-S-E, for the anatomist who noticed this and thought about it a little bit. And in that space, there's a resident macrophage lounging around, a Kupffer cell waiting for some action, and there may be a lymphocyte stuck in here, now and then they pass through, maybe a fat storing cell, an Ito cell, but there isn't a lot going on in that space. There's a wispy kind of connective tissue, a little bit of collagen 4, some proteoglycans, a little heparin, various wispy bits of architecture, but the basement membrane is just not there. And that's a normal situation. And so you can imagine blood's flowing from here to here, but it's leaking out into the sinusoids, and everybody's happy, the macrophages and the liver cells and so on. In cirrhosis, regardless of cause, regardless of mechanism, what happens is that basement membrane begins to creep down and close off the sinusoids, the defenestration of the sinusoid. And now there's no longer the openings, there are no longer holes, there's no longer fenestrations. The space of Disse gets clogged with connective tissue. The connective tissue is mostly large fibrillar collagens, but there are a variety of other molecules as well. And they're all produced, or probably all, nearly all, by the fat storing cell, which in this setting becomes a little factory of collagen and matrix production. And when stimulated by the problems that cause cirrhosis, is provoked to put out all that connective tissue that makes basement membrane and that clogs up the sinusoids. And so now you've taken a nice spongy circulation and you've turned it into a lead pipe. And the blood flow from here to there can go by without the hepatocytes much seeing it. Okay? The hepatocytes no longer have that same access. Furthermore, they're going to have their phenotype disturbed by all this matrix, to which they're quite sensitive. And furthermore, whatever was causing injury in the first place is likely to be injuring them. So in chronic liver disease, the things that go on day by day, a little injury, never so much as to come to the patient's attention, but unrelenting. Gradually, you close off the sinusoids, you clog up the space of Disse, you distort the architecture of the liver, and you develop cirrhosis. So it really all begins there on that basis. If you put it into another form, now we're going to kind of look at a plate of hepatocytes here, and we have this endothelial cells. They almost look like little ravioli or something here. They should have put some little holes in them to help orient you. But here's supposedly the normal architecture. So this is the space of Disse between the hepatocytes and the endothelium, and there's a little Kupffer cell on the inside this time, and a little stellate cell or fat storing cell. But here in the setting of cirrhosis, that space is all clogged up with inflammatory material and with collagens in particular, and then a couple of cells have gotten knocked off. The Kupffer cells are swollen and reacting and trying to ingest debris, and the whole architecture here has been distorted by the process. There are implications for the circulation that are pretty profound. As I was saying, if you have a spongy organ, you can't really force the pressure up very well. If you have a normal lobule of the liver, here's a portal vein, here's a central vein, and the blood is flowing through this way, maybe it's taking a channel here, or maybe taking a channel there. There's a lot of unused kind of capacitance there, not to mention the leaking of the blood into the space of Disse. You run the volume up here, what happens is you merely expand the number of sinusoids that are being perfused. You can change the volume per minute. Here's the volume per minute through the portal vein. Bump it up by 1,000 cc's per minute, and the pressure hardly budges because you just have all that capacitance. All the blood leaks into the space of Disse, and more sinusoids become perfused, and not too much happens at least until you get to really, impossibly high blood volumes before you see pressure change in the normal liver. Pressure, as you know, is a product of flow and resistance. And when we start taking away the fenestrations, we're increasing the resistance to blood flow, right? We no longer have that space to which you can leak. So when you defenestrate the sinusoids, some people say that it's the capillarization of the sinusoids. They look more like capillaries now than sinusoids. They no longer have their holes. You'll see all that nomenclature. That means you've lost compliance or increased resistance. Now your pressure can really go up. As flow increases, your pressure can go up quite high. So if you take, these are animal experiments, but the same things have been observed in humans. If you take a flow rate through the portal vein and either add or subtract, the pressure in a normal liver doesn't budge much, a tiny bit, a millimeter or two of mercury. But in a cirrhotic liver, it's tremendously changed. And it just turns out as you increase pressure in the portal system and develop portal hypertension, all kinds of bad things happen. And they happen with very small changes in pressure, very small changes. And we'll see a little bit about that as well. So it's really, I think, a kind of a key concept that changing the capacitance of the liver is a huge problem in cirrhosis. And needless to say, what that means is if you really want to fix the problem of cirrhosis, you want to focus on the regulation of those molecules, collagen and the proteolytic enzymes that might remove them and so on and so forth, because that's really where the action is. One more picture to just show you this again in another artist's conception. Here are hepatocytes on each side. Here's a sinusoid, the space of Dissy. These are supposedly the fenestrations in the sinusoidal cells. They've made a fat-storing cell here that looks like it's from Jupiter or something. You can see little flecks of fat. This is a lot of vitamin A is stored in these cells, and that's a normal circumstance. It's kind of a big myofibroblast. But in the setting of cirrhosis, they contract, which in part closes or decreases the diameter of the sinusoid, and then they make collagen like crazy, and they seal up those fenestrations and capillarize the circulation, and portal hypertension is the result. This slide is only to ignore, I guess, basically. But there are different diseases here. All of them have different mediators. All of them end up with a fat-storing cell making collagen and resulting in cirrhosis. We know a lot about the various mechanisms by which these things happen. But the point of this is that all the liver diseases we know so far funnel down to the same process of the fat-storing cell clogging up the sinusoid. All of them, through their various mediators, incur the cell death and injury of hepatocytes and fibrogenesis. Fibrogenesis is the process over time that results in cirrhosis. And that results in the loss of vascular compliance, the loss of normal and mature hepatocyte mass, and their normal phenotype. So really, the microarchitecture determines all the protein manifestations of cirrhosis. Now, when you look at liver biopsies, it's a little simplified when we talk about fibrosis. Everything in medicine has a scale of 4, right? There's none, there's a lot, there's something in between. In liver fibrosis, 1 is the early stage, a little bit of extra fibrosis, mostly in the portal tracts. There's always a little extra matrix in the tracts. I mean, that's where the conduits are. That's where the bile ducts and the hepatic arteries and portal vein are. Something has to hold them together so they don't flop around, right? So there's always a little collagen in there. But as scarring begins, it starts there, and then it extends beyond there, and then it begins to bridge between the various venous structures, and then finally there's just total nodularity. So the really important thing is not what stage of you have on a biopsy. The really important thing is, do you have enough to cause portal hypertension and the badness that we'll see clinically here as we follow along. But I should at least show you, these are kind of crappy pictures too, but if you think of blue as fibrous, that there's a little blue in the portal tracts in stage 1, maybe that's a little more than normal. You have to just sort of take that on faith. But then it's expanded a little bit, and now it's starting to bridge between, and then finally you subdivide the liver like we saw in that first slide. So when you read about liver biopsies and fibrosis, it's always sort of simplified in this way. The action is in the sinusoid, but we're not seeing that on a biopsy. So this is a surrogate for how much fibrosis is taking place, but the important fibrosis is really down in the sinusoids. There's a gradient of scarring, just like there's a gradient of pressure, just like there's a gradient of clinical disease, and it all depends on how far along this process has gone. And in fact, this isn't a great slide, but it's a useful concept. We're looking at, except I have to read it here because I can't see it there. On the left side, we're seeing a column of titles, and we're going from non-cirrhotic up above as we go down in each column to cirrhosis at the bottom. And let me see, I'm not seeing that very well. The things I want to make clear are, okay, here we go. So as fibrosis increases from here to here, as we go from stage 1, 2, 3, 4 in a biopsy, we're going from non-cirrhotic, compensated cirrhosis, decompensated cirrhosis clinically. On symptoms, we're going from probably none to starting to have them to having them in spades. If you're looking at, skip the staging for a moment, that's not important. If you're looking at that pressure gradient, that is how much pressure is now in the portal system, less than 5 millimeters of pressure is typical on a nice spongy liver. When you go from 5 to 10, you're in that range of cirrhosis with compensation. Once you get above 10, it's a very narrow span. By 12, you can have bleeding varices. We're going to look at that in a second. Once you get above 15 or 18, you're going to die in the next few months. So a very narrow band of pressure between normal and abnormal. In fact, if we could have measured pressures 100 years ago, we would never have bothered to look at biopsies. This is much more predictive of where a person is in the scheme of liver disease than the biopsy. Biopsy is pretty good, but a biopsy can have slight heterogeneity. You might miss the worst place. You might get a place that looks a little artificially better because you're only getting that 1/20,000th of a liver in a biopsy. The pressure is measuring pressure in the whole liver, and that gradient is very steep and very predictive. But all of these things are spectra, and biologically, of course, we have a little bit of fibrogenesis going on, and we have some more substantial scarring, and finally we have nodularity. So the concept of the gradients looked at by various methods, by pressures, by histology, by patient signs and symptoms, by their clinical appearance. So how do we measure the pressure? That's worth looking at. And so bear with me, we'll look at this slide. It's actually made up of familiar elements in a new configuration here. Here's a cirrhotic liver. It looks kind of nodular. Here's the portal vein coming in. We've taken out the hepatic artery out of this discussion, but the hepatic artery blood is going to merge with portal blood in the liver. It's there. It's just not terribly important to our discussion. So here's the portal vein. It's coming from the splenic vein, and the mesenteric veins here. Okay? And it's going on into the liver. Here's the hepatic vein that's draining back out. And in between is the matrix of the liver. And we've got hundreds of thousands of little lobules, but we're going to just look at one. Here's one lobule. We've sort of blown it up. We're already down to the point where we're going to say there's a central vein, and that's draining this way, and we're coming in through the portal, one of the portal tracts. So let's blow that up and say, here we are. The portal venule has come in. Now, this is like the picture we've seen on histology so many times. Portal vein flowing between the hepatocytes to the central vein and out. So we've reduced the whole liver down to one lobule. Now imagine you can pass a catheter down this vein all the way down to this lobule and wedge it in. In fact, you put a balloon on that catheter so you can blow up the balloon, and the pressure transducer you have at the tip is now shielded from all back pressure, and it's just measuring the pressure in this lobule. Okay? You can do that. That's how you determine the pressure in the liver. That's how you take the pressure you measure in the lobule, subtract the background pressure of the vena cava, and you've got the portal venous gradient. That's a number that should be less than 5. That's a number that between 5 and 10 is abnormal, but it's still compensated. That's a number above 10. You start to have decompensating events. That's how you would measure it. The radiologist, interventional radiologist, can do this. We call it getting a wedged pressure of the liver, or a hepatic venous gradient, portal venous gradient. That's how you would make that measurement. It takes a little time to do. It's not a daily event, but it's certainly a weekly event in patients where it's important to have that information. Does that make sense? It's sort of putting together pictures we've seen of the vascular anatomy and the microanatomy to show how we can get through the macroscopic anatomy and make measurements in the microscopic anatomy. So, let's talk about some cases that'll help us to talk about prognosis. And let's talk about some of these consequences of portal hypertension, the badness that I keep referring to. Case number 1, and I'm going to give you these cases and string you along for a while so that you can kind of think about it, and then we'll add a few concepts and come back to them. And I hope they'll make a point about how we assess the significance of liver disease in real life. So we'll talk about case 1. 46-year-old man who has been consuming alcohol fairly heavily, but he quit a few weeks ago for just didn't feel like drinking much anymore. His chief complaint is fatigue, and he's pretty profoundly fatigued. He's not taking medication. His whole past history is basically an appendectomy. As far as we know, doesn't see the doctor very much. And when you look at him, you can see his eyes are yellow, so you know you've got your colorimetric assessment. You know he's got liver disease already. You notice when you're talking to him, he keeps sort of falling asleep, or at least he's nodding off. He's got some, when you talk to him, he says he has trouble at night sleeping, and then he's napping during the daytime. He says he has no appetite to speak of. And he certainly has increased abdominal girth. He looks not maybe as bad as that slide I showed you, but he's kind of got that same disproportionate abdominal swelling, and then he has some edema. So you do some lab tests, and you see his white blood cell count is 2,200. That's low. His hematocrit is 34. That's low. His platelet count is 45,000. That's low. So he has pancytopenia, right? All the lineages of cells from the bone marrow, white cells, red cells, platelets, are all reduced. His AST and ALT are both slightly elevated. You have to take my word for it. I'm not putting the normals on this slide, but that's semi-deliberate. I mean, whenever you go and look at lab tests, the lab is going to have its own normals. They're going to have standardized it for the local population, and so you have to just kind of get used to the fact that in some labs the upper limits might be 40 and some they might be 60, but these are 1.5 times normal, say. Alkaline phosphatase 140, that's a teeny bit up, but his bilirubin is high, 4. His INR is elevated, it should be 1. His albumin is low, anything below 3 is pretty darn low, and even his kidney function is not great. Creatinine should be 1 or maybe less. So having seen these as your screening test, you do these, and you find that he doesn't have hepatitis B or C. You check a quick alcohol level. He said he wasn't drinking, but it would be relevant if he still was, and he's not. Alpha-fetoprotein we'll come back to at some point. That's a marker, could be a marker for cancer he does not have. And an ammonia level, ammonia levels are drawn too often, but an ammonia level is a surrogate marker for all the toxins that the liver is not taking out. Okay? It is itself probably partially responsible for the confusional state of hepatic encephalopathy, but it sort of stands as a marker for how inadequately the liver is taking toxins out of the bloodstream. And 90 is quite elevated. So you've already built a picture of somebody who could have alcoholic liver disease, doesn't have viral liver disease, but definitely has chronic liver disease, and everything about it looks like cirrhosis on paper anyway. The physical exam, he's slow. That is, when you speak to him, he's slow in response. You just met him. You don't know if that's the way he is or if that's a manifestation of hepatic encephalopathy. Asterixis is a particular tremor with a kind of a flapping quality of maybe 2 or 3 cycles per second that you have with muscles when you try and hold them in suspension. It's a late finding in patients with hepatic encephalopathy. You just ask a patient to put their hands out like they're stopping and if you see them doing that, then that's asterixis. He definitely has muscle wasting. He has gynecomastia. He has breast tissue that he should not have. He's jaundiced. He has angiomata, spider angiomata, and pulmonary erythema. And his abdominal exam shows distension and shift. When he moves, you find the dullness in his belly shifts as if there's fluid that's swashing around in there. Can't feel his liver or spleen. This is a spider angioma. It's a little vascular lesion, often on the chest and neck. Not to be confused with telangiectasias that you can get from sun exposure and so on. It's got a central arteriole, and if you put your finger on that, the whole thing would blanch and go away. And when you took your finger off, it would fill here and then fill outward. So you would know it was filling from a central arteriole. In cirrhosis, for a variety of reasons, there's a relaxation of precapillary sphincters, and so you may see these spider angiomata. Anybody could have one, but if you have 2 or 3 or 4, it's almost always chronic liver disease. So that's a sign on an exam that's helpful. Even when you can't feel the liver, you're seeing something that tells you about liver disease. This is pulmonary erythema. You can see that sort of redness on the sides. That's not totally liver specific. You could have that in some thyroid disease. Sometimes you can see it in pregnancy, but in this context, it's also consistent with and reinforces your belief he has chronic liver disease. You can see here, this is probably, there could be some fat here, but doesn't it seem a little grape-like? It's a little There's a little bit of roundness up here you might have thought would be more saggy if it was all fat. You kind of get the impression there's maybe some extra tissue here. You can't see spider angioma at this point, but you can kind of get a sense that there's some muscle loss and everted umbilicus. These are all findings typical of chronic liver disease and cirrhosis. I'm going to remind you one more time, because we're going to keep coming back to this. AST, ALT, alk phos, slightly elevated in this guy who clearly has severe liver disease based on everything we know about him. We're going to let that sit for a moment. A guy who clearly has chronic liver disease by signs, by lab, but the alk phos and the AST, ALT are pretty nonspecific. Here's a second case, 68-year-old female. Her chief complaint is also fatigue, so they're the same in that respect. Her past history is a little more elaborate. She's had coronary artery bypass grafting. She's had a mitral valve replacement. You hate these abbreviations, but you just kind of have to get used to them. She does not drink alcohol. Her only medication is a statin for cholesterol. She takes some daily aspirin. Family history has coronary disease and diabetes, but no liver disease. She really denies any signs of bruising or edema, or she doesn't have any increased abdominal girth above good old-fashioned abdominal girth. She's not jaundiced. Her weight's unchanged. She has no confusion or sleep disturbance or anything. In other words, she's pretty much fatigue and fatigue alone. And on exam, well, I can't remember if I put an exam on, but I'm going to tell you it's pretty normal. But she did have an ultrasound. Somebody did an ultrasound, and she has an irregular liver contour, as if there's some nodularity there, although she does have normal blood flow. Her lab is identical to his lab. ASTs, that is, for these numbers. AST is 78, ALT 60, alk phos 140. Identical. Okay, same numbers for those numbers. On the other hand, her albumin is also low. Her INR is normal. Her total bilirubin is normal. So it's not quite perfect there. Okay? And her kidney function is normal. And her platelets are low. His were lower, but they're both low. So she has some abnormalities here, but the transaminases and alk phos are identical to our other patient. You do a set of lab tests, and in her case, her hepatitis C antibody is positive. She has hepatitis C, and you could already guess that if she had her coronary artery bypass grafting back in 1989, that was before we discovered hepatitis C. We knew there was something in the blood bank, but nobody knew how to screen for it. She almost certainly got hepatitis C at the time of that surgery. There's a large cohort of patients who got hepatitis C from surgery back in the 80s. That cohort is shrinking, but they're out there. So, could either of these patients have cirrhosis? Well, I already kind of tipped you off on the first one. Could the second one? How could we find out? Should we care? What difference does it make in terms of how we proceed with them, treat them, monitor them? And what do we know about their prognosis? If they do have cirrhosis, one of them certainly looks worse in pictures, but do they have comparable or different prognoses? And then how does the prognosis tell us what we should do? So I want you to hold those cases in mind, and we'll catch up with them after we go through some of the manifestations of this disease. I should tell you what this slide is about. The badness of cirrhosis comes about, in general, by two basic principles. Either blood cannot go where it should go, and so it shunts and doesn't pass through the liver, or in passing through the liver, it never sees the liver cells because of the capillarization of the sinusoid. Or badness arises because the liver cells can't do what they're supposed to do. And both of those things are operational at all times, but it's useful to think about it because there are a couple of, kind of helps you to sort of derive the expected problems that occur as fibrosis increases. So let's go back to this same slide. We've added a few things this time, though. This is a slide again showing the input through the portal vein. Splenic vein, the spleen is sort of taken out here, but it would be lying on this, over this spot. And then there's the inferior mesenteric vein from the low colon, and the superior that would be taking blood from the small intestine and the stomach and so on. and all that blood should run through the portal vein. What we've added this time are the collaterals, or I should say the detours, where blood could exit the portal system and find its way to the caval system, right? All these pictures show the vena cava cruising right through the liver. I mean, it passes through the liver and into the superior vena cava and right into the right atrium, and it's not taking any blood flow from the bowel or the intestine.